I'm pleased to be joined today by Darilyn Moyer. Darilyn is the Executive Vice President and Chief Executive Officer of the American College of Physicians, which is the largest physician organization in the United States. She'll be starting her fifth year in September. Darilyn, thanks for joining us.
Thank you for inviting me. It's a pleasure.
So, Darilyn, you're also an infectious diseases specialist, so you have a unique perspective on the COVID-19 pandemic. I'm curious, as someone who still sees patients in Philadelphia, what's happening kind of on the front lines?
Well, I am an internist first. Once an internist, always an internist. And I'm also an infectious diseases physician. And as a former internal medicine residency program director, I continue to see people part-time in the residency internal medicine community-based practice at Temple Hospital. And what's happening on the front lines in Philadelphia is that we are still in the midst of having our first peak of the COVID pandemic. There were some thoughts that possibly we were seeing some receding of the numbers, but it's pretty clear that we're still at the top of the curve for this initial onslaught. I think the other important point here is that this pandemic is demonstrating the health inequities and really amplifying. We already had significant health inequities in our society, and I believe that this pandemic has really ripped open the underbelly of that, as we're seeing our poorest communities of color, that are being predominantly affected here in Philadelphia.
Yeah, we're seeing the same thing in the sort of greater Washington, D.C. area in terms of the health inequities. What, if you could sort of outline a 3 or 4-step strategy post-pandemic to address some of those issues based on what you're seeing, what would your kind of goals be?
Well, first of all, the ACP put out a series of papers in January of this year, Better If Possible, A New Vision for American Healthcare. And I would urge your readers to go back and take a look at those papers, which were published as a supplement in Annals of Internal Medicine in mid-January. And we essentially have an executive summary paper, a paper that looks at cost and coverage, a paper that looks at payment and delivery system reform, and a paper that looks at public health and addressing social indicators, determinants of health and health inequities. We really chart a path which was extremely prescient for what we're experiencing now regarding ensuring that everyone in the United States has coverage for their care and access for that care. And we chart 2 mechanisms by which that could happen, and that could happen with the system we have right now, which is a pluralistic system of employer-based insurance and adding a public option onto that, or through a single payer. We talk about shoring up and funding a connected public health infrastructure that is connected into the community. And so obviously would have antennae up when something like the COVID-19 epidemic is taking hold in the community, would have a much quicker early warning system for that. We also, in that series of papers, talk about the financing of healthcare systems, and I think that, again, what this epidemic has demonstrated is the large chasm between the haves and the have-nots in healthcare. Certainly seeing the broad contrast between health systems that are all struggling right now, but many are struggling a lot more than others are, particularly those that run on thin margins to begin with. And what we talk about is an all-payer system with global budgeting. It's very similar to what Maryland has at baseline in their state. In terms of having that sort of global budgeting in order to help to sort of make sure there's more of a level playing field for all the hospitals and health systems throughout that state. So, I mean, I think it really is, it's having, and I think that the large raging epidemic of unemployment that has accompanied the pandemic has demonstrated that while we have, a decent employer-based insurance system, this is exactly the stressor that is really going to illustrate that now you're going to have 30, plus million people that are unemployed, in addition to the 33 million people that were uninsured at baseline. And this is a huge stress on the system. And, it's important that everyone have access to care, access to appropriate coverage, so that people are not basically not seeking care when they're ill, whether it's from something like COVID or it's from one of the many other acute and chronic diseases afflicting our citizens.
I've heard a few people make the observation that if this situation doesn't move us from a policy perspective in the direction that you're outlining, then basically nothing will, but it'll just continue to deteriorate. Would you, I normally try not to ask yes or no, and ask yes or no questions, but I'm just sort of curious if you think that assessment's correct.
Oh, I think that if there anything should be the catalyst, this is sadly, the exact catalyst that should really get us all into action and say, never again. We know that this pandemic is not over. We know there's going to be lots of activity until we get a successful vaccine and have a good portion of the susceptible folks vaccinated against it. So if anything should galvanize our action, this catastrophe should galvanize our action to get to a better place so that we are much better prepared and have the ability to address all of the issues that have come up and really been magnified and amplified by this pandemic.
So you and I get to spend a fair amount of time in various meetings with our counterparts at other societies and specialty societies and subspecialty societies. And you've made a couple of observations, one in January and then one recently, just around the one in January. One of the papers in the ACP series, which I would recommend for everyone to read, was around the responsibility that ACP and other specialty societies have related to culture change. And you were talking about, as someone who's an expert in infectious diseases, seeing infectious diseases in one part of, I believe it was in the Gulf of Mexico, then being up in sort of off the coast of Nova Scotia.
Yes.
And it really stuck with me as sort of an interesting public health issue. And then I've also heard more recently an observation you made around, yes, this is a 100-year flu, but it's possible that we'll have more 100-year flus over the next couple of years. Mm-hmm. I'm just trying to get my mind around both what's happening with the sort of changing climate, but then some of these other issues related to pandemics and what we should be thinking about as we plan for the future.
Yeah, I mean, I think undoubtedly we are all interconnected. And there is no doubt about that. And the specific example I think I gave was about Vibrio vulnificus, which is a flesh-eating bacteria that particularly afflicts folks with liver disease and other predisposing conditions that was seen predominantly in the Gulf of Mexico in the warmer climates. And they're now having reports of it up in Nova Scotia. There is absolutely no doubt that there are significant effects of climate change on health. And it has to do with lots of things. It has to do with the very erratic weather patterns that, for example, has fueled malaria, chikungunya, Zika, and dengue to those epidemics, which are mosquito-borne epidemics, to have much larger territories and taking hold in parts of the world that we never saw them before. The Ebola outbreak in Africa has clearly been fueled by deforestation and issues around more intermingling of animal species with humans. And then generally the globalization and the fact that someone is over in the Wuhan province and may have been asymptomatic with COVID-19, gets on an airplane and flies to a meeting wherever and has close contact with a bunch of folks, and those people leave and go back to their homes, and voila, pandemic is born. So I think that unfortunately this was sort of a perfect pandemic prescription with this organism because it's highly infectious from what we can tell. It has what's called a very long serial interval, meaning there is a large amount of time between someone actually becoming infected and now infectious simply by talking to other people before that person might become symptomatic, if they become symptomatic at all. So it's sort of unfortunately that perfect storm of lots of things coming together. And I really am concerned that these epidemics are going to continue to accelerate because of a variety of circumstances that are teeing them up.
So I try to think of this from my role at ASN. Clearly, a big part of what we'll be doing organizationally moving forward is adjusting every aspect of the organization, but also thinking about policy-related issues for people with kidney diseases or kidney failure or kidney transplants. In this kind of context, I'm just curious as to how the American College of Physicians has started to approach its agenda, both in the short term related to the current pandemic, but also in addition to the papers you published in January, just more broadly as you think about the future.
Yeah, well, I mean, I think, as I said, those papers were really quite prescient in terms of the comprehensive guidance that it charts to get us to a better place in healthcare. I think we've had a multi-pronged strategy at the college, and I think one of the wonderful things that has come out of addressing this pandemic is to see how closely our community is working together to get to a better place. In terms of resources, before we get into the policy, we rapidly stood up in the middle of March a COVID-19 website that was curated in real time. In fact, it was getting curated several times a day as we were just getting more and more evidence. It was wonderful to see our partners from the internal medicine subspecialty societies, contributing important information, cutting edge information to help the clinical management and the practice of medicine for our members. And we stood this site up actually to be freely accessible to all without any wall that you have to go behind. And we're happy to see that it's the number 2 physician resource for COVID-19 after the CDC. So we continue to curate that in real time and get lots of submissions as evidence is accumulating and changing. I think the other really important arena that happened quickly, and I like to say that COVID did in 20 days in terms of practice transformation into telemedicine, what hadn't happened in the 20 years prior. We have been in the process at the ACP of developing broad curricula and resources around telehealth and telemedicine. And so we're very quickly able to rapidly stand that up and continue to add a lot of great practical resources. And as you mentioned, with all of this comes the policy and the advocacy that has to come around this. And, we're very concerned about what we're seeing on the front lines, both at hospitals and large healthcare institutions, but also what's happening with our members who are in smaller private practices, and the concern that in the interest of maintaining folks' health, they were telling people not to come into the office, which was completely appropriate. But we needed to make sure for folks that, have to work until 3 p.m. every day just to keep the lights on in their office, that they were going to stay in business to be there for their communities. So lots of work in terms of getting CMS and the commercial payers in terms of appropriate telemedicine coverage and appropriate parity. Again, I work with a patient population that doesn't always have a landline, let alone a cell phone with smartphone capacity. And there's a lot of issues around the country with broadband access. So a lot of patients only have a landline, or they have a less sophisticated cell phone to talk to their physician. So we were very happy to see one of the major areas that we pushed through, of course, was around the pay parity for telephone audio only calls. We've also been very, very concerned about what we were seeing in terms of infection control, inadequate personal protective equipment for our frontline healthcare professionals, and have certainly, developed a lot of policy around that, and have also, been concerned about some of the business practices that we've seen in terms of some of these healthcare professionals getting sanctioned for going out and discussing these issues around infection control and PPE inadequacies by their organizations. I read last week that sadly, there's been over 2,700 OSHA complaints that have been lodged against hospitals and healthcare systems by their employees in the midst of this. The bottom line is, we need to get to a better place. We need to get to a better place for patient care. We need to have a better early warning sentinel surveillance system and better connections between the folks on the front lines in our communities who are seeing clinical things that raise their antennae, and the public health authorities. And we need to have a better plan moving forward where everyone is connecting, collaborating, communicating.
Yeah, you'd mentioned earlier the fact that you were a internal medicine residency program director, and you've spent a lot of time, pretty much your entire career, working around medical students, residents, fellows. One of the parts of the situation that I'm really concerned about, I know what we hear from our members, is what's going to happen sort of with trainees, particularly those that have been pulled into service kind of on the front lines. And I'm just curious, given your experience, what advice you'd have both for nephrology as a community, but also the broader sort of, as you said, house of internal medicine.
Yeah. I mean, I think this is a real call for physicians to step up to leadership positions, and healthcare systems, other stakeholders in healthcare, to ensure that the folks that, have their fingers on the clinical pulse are also the people that are the decision makers and the leaders of that clinic, that dialysis unit, that hospital, that healthcare system. I think it's absolutely crucial that we not just bootstrap physicians on the front lines to doing clinical work, but we understand that not only do they see all of the issues that are undermining quality and safety, as well as being our early warning system, they also in the next breath frequently know how to fix it, or at least know who to get to the table to get it fixed and to have that discussion. And I think this is a real call for organizations in the healthcare space to be able to foster the professional development of their physician leaders and empower them in a way that is going to help everyone else run those healthcare systems. So I think that's critical. That again, we know, we see what the issues are, and in the next breath, I think we know a lot of the solutions are potential solutions. So I do think that that's going to be critical as we move forward here. And I think the other thing is that, our physicians keep patient care as their North Star. That is what guides them in their, minor decisions every day, major decisions every day. And I think that once again, that's critical. And we need to push back against business practices that do not hold patients as our North Star. And I think that that's critical in this environment. And I think that there's a call here for physicians to really have a strong voice. I think there's been newfound respect seen in the healthcare profession, particularly for those folks on the front lines, like the physicians and the nurses. So I think this is an incredible opportunity that we can't miss to once again really pull together and speak with one very, very loud voice.
Well, I think that's the perfect note to end on. So thank you for taking the time. I know how busy you are, so I really appreciate it to chat with me about this issue. It means a lot.
Thank you for inviting me. It was a pleasure chatting with you. A couple of my best friends are nephrologists. I have incredible respect for the nephrology community. I know, particularly putting themselves at risk every day in dialysis units, taking care of all those, patients who are showing up for emergent dialysis in emergency rooms. So my thanks to you and to all of your listeners.
This podcast is copyrighted by the American Society of Nephrology, all rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare provider if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.